Hello everyone, welcome to the learning of fundamentals of pharmacology, and this session is about pharmacodynamics and pharmacokinetics. Let's go to understand the pharmacodynamics and pharmacokinetics. So, to understand what happens when a drug is administered, we as nurses, we must understand what is pharmacodynamics and pharmacokinetics. So, pharmacodynamics is how the drug affects the body, and pharmacokinetics is how the body reacts then to the drug. These two processes forms the basic of instructions created regarding medication administrations. For example, why certain agents are given intramuscularly and not intravenously, and why some drugs are given with food and others after or before meals. And also, what is the standard dosage that should be used to achieve the desired EVAC from the drugs. Knowledge of these basic principles of pharmacodynamics and pharmacokinetics then helps us nurses anticipate the therapeutic and side effects of drugs and intervene in a ways that ensure that the patient's drugs regimens is effective and safe. So, as I mentioned before, so when we understand the relationship between man and drugs, we know that the drugs is being taken by human, and we also have what we call pharmacodynamics, that what the drugs does to the body, and then the pharmacokinetics, what the body does to the drugs. So it will then be beneficial and have the desired effect. Now let's talk more about pharmacodynamics. So pharmacodynamics is the science that studies the interaction between chemical components in the living system or inside the body of a human and foreign external chemicals, including the drugs that enters this body. And all living organisms function through complex stages with continuous chemical reactions, and many changes can disrupt the cell functions when a new chemical enters the system. So, to prevent this, drug development functions to provide the most effective therapeutic use and provide at least amount of um, toxic and poisonous chemical. The drug action actually works in one of the four ways. The first one is to replace or works as the substitute for the missing chemicals and to increase the stimulation as in certain cellular activities as well as to suppress or slow down cellular activity. And the last one is to interact or to interfere with the function of foreign cells such as invading microorganism or neoplasm. And this will be the drug that work and the way that we call chemotherapeutic agents. And medications may work in several ways, one or more of these ways, to then achieve the desired results inside the body. Now let's talk about the receptor sites. So the drugs then will work on a specific areas on the cell membrane that called receptor sites. So this is the receptor sites. And this receptor area will then react with the chemical that is then causing the effect inside the cell. In many situations, the adjacent enzymes break down the reacting chemical and open the receptor area for further simulation. To understand this process, let's think about how a key works. So the key and the locker. A specific chemical will then be the key, and it will approach the cell membranes, and then it will then find the perfect fit or as the lock in the receptor area. And this interaction between chemical and receptor affect the enzyme systems inside the cells. The activated enzyme system then produce certain effects such as increasing, decreasing cellular activity, changes in the cell membrane permeability, or changing even the cellular metabolism. So as you can see here, this is the chemical or the molecules within the drugs, and then it will then goes through the cell membrane, and then this receptor site will then try to meet the molecules, and then it will fit, then cause a desired effect. If it doesn't fit, for example, like this one, then it will have no response and it will not cause the desired effects. Next, let's talk about the agonist and antagonist. So, agonist is the drugs that occupy receptors and then activate them. Antagonist is the drugs that occupy receptors but then do not activate them. And antagonists usually block the receptor activations by agonists. So if you can see here, this is a fully activating. We have the agonist, and then the agonist will then go to the receptor site, and then it will fit, and then it causes a full activations. What happens if we have agonist and antagonist? So both of them will go to receptor site, but then it will cause less activations. But then when it's only antagonist alone, what happens is it will fit to the receptor area, but then because it's antagonist, it will cause no activation. So some drugs interact directly with the receptor to cause the same activity as natural chemicals in that area, and these drugs are called the agonist. Example, the insulin will react with the insulin receptor and change the permeability of the cell membranes. That's why the glucose will then have movement to get into the cells. Another drugs that prevent the natural breakdown of chemicals that stimulate the receptors. For example, monoamine oxidase inhibitor. It will inhibit the breakdown of norepinephrine by the MAO enzyme. So MAO will normally break down the norepinephrine, so it will release it from the receptor and recycles the component to form now norepinephrine. The inhibitory actions of MAO inhibitors cause norepinephrine to remain at the receptor and stimulating cells longer and prolonging the effect of norepinephrine. This effect can be therapeutic, for example, for curing depression, or bad side effect or detrimental effect, for example, increasing heart rate and blood pressure. Now let's talk about competitive and non-competitive antagonists. So we have what we call weak agonists and strong agonists. So if you see, these two drug agonists are attaching to the receptor sites. But then the drug agonist that has exact fit is a strong agonist. So like this one, it's like fit to the receptor site, so it will then cause an activation strongly. But then the other one is the weak agonist. So more biologically active than the weak agonist. So if the strong agonist come, then the cell will be biologically active. But then if the weak agonist that coming here, the cell won't be active as the strong agonist. So some drugs will react with the receptor to inhibit normal stimulation and produce no effect. For example, a curare. So this is the drug that used to paralyze prey and cause death in Amazon. So it is the receptor for acetylcholine, which is important for muscle contractions and movement. So curare prevents muscle simulations and causes paralysis. So it is said that curare can be the competitive agonist to acetylcholine. Other drugs react with specific receptor on the cell, and by reacting there, they prevent other chemicals from reacting with a different receptor on that cell. And these drugs are called non-competitive antagonists. Now let's see this picture. So we have the drug A and drug B. So drug A will then bind to the receptor site. As an agonist, so the drugs A will then clearly be binding to the receptor site on a cell. But then drug B cannot because it's not the same match. So then it will cause no effect to the cell. Now let's see the competitive antagonism. So we still have the drug A, a little one, and drug C, a bigger arrow. So the receptor side actually then bind with the bigger arrow because it's a competitive antagonism. So the drug C will bind to the receptor site and cause drug A to not be able binding to the receptor site. That's why drug C is preventing drug A to then have effect on the cell. Now let's see the non-competitive antagonism. So we still have the drug A. It's an agonist, but then we have drug D. Drug D is like very big and then competitive antagonist of drug A, and it can bind anywhere. It doesn't need to be in the receptor side of drug A. But then when the drug D come to the cell, drug D will bind anywhere, but then prevented the drug A to then be binded by the receptor side. So the drug D completely being the antagonist here and then preventing drug A to have effect on the cellular. Okay, now let's move. Now we learn about drug enzyme interactions. So drug can also cause effect by interfering with the enzyme system that catalyzes various chemical reactions. The enzyme system works in cascade effect, with one enzyme activating another and then ultimately causing a cellular reaction. So if you see here, we have a metabolic activator that attached to the cells, and then the cells would then help all the enzyme 1 to then take action, and then the enzyme 1 will then stimulate enzyme 2 to then also have reaction, and then this will cause a physiological effect in cells and tissues. If one step of the enzyme systems is inhibited, normal cell function will be disrupted. So, for example, we have a drug that then cut the enzyme 1 here. So then the physiological effect in the cells and tissue won't happen. It will not happen because it has been disrupted by the drugs. Okay, now an example of medicine is what we call acetazolamide or Diamox, and this is a diuretic that inhibits the carbonic anhydrase enzyme, which causes changes in hydrogen ions and the water transfer system inside the kidney. So here the process, and then we will put then the Diamox over here, so then it will changes the system of water transferring within the kidney. So that's what happened between a drug enzyme interaction. Now we talk about selective toxicity. So, ideally, all chemotherapeutic agents will not only work on enzyme systems that are important for the life of a pathogenic or neoplastic cell, but will not affect healthy cells. But the ability of a drug to attack only the system found on foreign cells is known as selective toxicity. For example, penicillin. It is an antibiotic that is used to treat bacterial infections, and it has the selective toxicity. So penicillin can evac unique enzymes in the system inside the bacteria that causes bacterial cells death without disrupting the normal human cell function. However, most other chemotherapeutic agents are also damaging the normal human cells, causing many of the adverse effects associated with antipathogenic and anti-neoplastic chemotherapy. The cells that reproduce or replace quickly, such as the bone marrow cells, digestive cells, and hair follicles, are very easily affected by these agents. Consequently, many chemotherapeutic regimens aim to deliver a dose that will be toxic to the invading cells and cause the least toxicity to the host. So with selective toxicity, it's supposed to be only attacking the one that is having problem. But then some and most of chemotherapeutic agents, they don't have this selective toxicity, so it causes like all the cells to be disturbed, such as the fast reproduce and replace cells. Now let's focus on the pharmacodynamics. So as you can see, here are the pictures of the drugs. So when the drugs is delivered to the body, it will then go through the stomach. And then here, the drugs will be ingestion, absorption, distribution, and metabolism, and also clearance. But then how the drugs, this is called pharmacokinetics. But then how the body then works against the drugs is what we call pharmacodynamics. So it's the process of a drug working inside the body. And the drugs can work by replacing the lost body chemicals, stimulating or suppressing cellular activity, and also interfering with foreign cells functions. The drug works by reacting with specific receptors or by interacting with enzyme system inside the body. So for example, we have a drug here, and then we have what we call blood-brain barrier or the other membrane system transport, but then the medicine cannot pass through this one, so that's what happened, that it won't come to the target organ. Now, let's learn about pharmacokinetics. So, pharmacokinetics include the study of the absorption, distribution, metabolism, and biotransformations, and also excretions of the drugs. In clinical practice, pharmacokinetics considerations include the onset of drugs, half-life of drugs, time of peak effects, duration of effect effects, metabolism or biotransformations of the drugs, and the area or locations of secretion. So let's see. We have an image here. This is the process of a drug inside the body. The dotted lines indicated that some part of a drug and its metabolites may be reabsorbed from excretory organs. So we have a drugs, right? We distribute the drugs, and then the drugs will be then absorbed. This drug actually come from the digestive tract, muscles, or subcutaneous tissue. But then the drugs will then bind with the plasma protein or albumin. And then here where the drugs will be then transported or distributed to the sites of action for therapeutic and sometimes also toxic reactions, and to the tissue storage sites such as fat and protein. And then there will be biotransformations of the drug in the liver. So once the drug enters the liver, it will then become the metabolites. And from the metabolites, it can be then distributed throughout the body to wherever it's needed, or then it also will be excreted by the kidney, gallbladder, or lung. Some of the metabolites also can be reabsorbed and then again following the procedures and then come to be excreted through kidney, gallbladder, and lung. So this is what happened. Now let's see again. So pharmacokinetics, remember ATME. ATME stands for absorption. So the absorption will be in the GI tract, stomach, and the intestine. And then distributions, it can be from the blood to the tissues, and metabolism is like mostly inside the hepatic, because then we will then divided the big drugs into molecules that can be absorbed throughout the body, and then the excretion will happen through the renal and also through the fecal. Okay, so I've explained about this picture, and I hope you remember ATME is for absorption, distribution, metabolism, and then excretion. Let's move on to the critical concentration. So once the drug is administered, its molecules are absorbed into the body. Then the molecules will find its way to then the reactive tissue. If a drug is to work properly on this reactive tissue and thus have a therapeutic effect, the molecule must maintain a sufficiently high concentrations in the body. So critical concentrations is what we call the amount of a drug needed to cause the therapeutic effect. Drug evaluation study determine the critical concentration required for a desired therapeutic effect. The recommended drug dose depends on the amount to be administered until it reaches a critical concentration. Too much medicine will cause toxicity effect, but then too little also will not produce the desired therapeutic effect. So remember this one. Too much causes toxic, less than what we want, it will not cause the therapeutic effect or the desired effect from the drugs that we hope to have. So now, for example, so we have the drug we give to our patient. So this drug will then go up to have the peak onset, and then it will then go out then to be excreted. So this one is what we call durations of the medicine. This is the effective dose, and this is the magnitude of effect, this one. And then we have like the peak here, and then we also have the half-life here. Okay, now let's talk about loading dose and maintenance dose. For some drugs that have a long period to reach a critical concentrations, if the effect is required very quickly, then we need to have what we call loading dose. So we recommend to use the loading dose. For example, digoxin or lanoxin. It's a drug used to increase heart contractions, and many of the bronchodilators, such as aminophylines and theophylline, used to treat asthma attacks, are often started with a loading dose. So a higher dose than normally given to achieve concentration critical. So the critical concentration is then maintained using the recommended dosing schedule, what we call maintenance dose. Now let's see this. So here we have what we call maintaining dose. So here is the maintaining dose. But we then here to receive the peak, we have what we call loading dose. And there are a lot of type of medicine. We have the sustained release tablet, the prolonged release, and then we have the conventions, all those. And this is how it goes. So this is the therapeutic range, and then to reach that, we have to do the loading dose until we receive the therapeutic range. But then to maintain the drugs to be inside the therapeutic range, we then have what we call the maintenance dose. Okay? Now, take a look at this one. We also have the drugs. This is the onset, and then it will reach the peak here, and then this is the duration. Okay? Let's move on. Now we learn about therapeutic index. So therapeutic index is the measures of the margins of the safety for a drugs. So it's actually the ratio that measures the effective therapeutic dose and the lethal dose. So therapeutic index is this one. So this is the effective dose, 50, and this is the lethal dose, like it's too much, so it costs something. And then we also have the drugs that with a low therapeutic index. So this is low therapeutic index. And then we have the drugs with high therapeutic index. So this is the high therapeutic index dose. Okay, so we will have like the dose 10 milligrams. So if it's like low, with 10 milligrams, we can have the pick one, therapeutic index. But then with the high, with the 10, we are not having, we also have here. But then with the lethal dose, we need like 50 milligrams to have that. But with the low one, we need like 20 to 30 milligram to then have the lethal effect. So we need to understand the um, effective therapeutic index. So if a low therapeutic drugs has a narrow margin of safety, then the drug should be closely monitored. For example, 10 milligrams is effective, but then when it's 20, it's lethal. So it's only like the lethal here that we need to have closely monitored. But then with the high therapeutic index, 10 milligrams is okay, 20 milligrams still within the therapeutic index. But then when we have like 60 milligram, it's like the lethal. So we have like less risk to then cause toxicity within our patient. Now, let's learn about dynamic equilibrium. So the actual concentration achieved by a drug in the body results from a dynamic equilibrium involving several factors. The first one, absorption from the entry area, then the active distribution, and then the biotransformation or metabolism in the liver, and then the excretions of the body. Remember, this is the ADME. So these factors are the key that determining the amount of drug required or the dose and the frequency of repeating the dose or the scheduling that is required to achieve critical concentrations for the expected periods. As a nurse, when we administered a drug, we need to then consider the pharmacokinetic phases or stages so that the drug regimen can be as effective as possible. So when we administer the drugs, whether it's orally or intravenously, we then remember that both of the drug will go through the absorption. And then when we do oral, it will then be absorbed through the enteric transport and metabolism. But then when we do intravenously, instead of having absorption, the drugs will then go through the distribution which is inside the intravascular space or extravascular space, or even directly have the protein binding. Then all the drugs will come to the metabolism. It will be inside the liver. So for hepatic influx transport, go through the phase 1 metabolism and also the phase 2 metabolism. After the drugs has then done its work to like cure whatever diseases that happen inside the body, the remaining drugs will then be excreted through excretion from biliary or intestinal or even renal. So this is what we call the excretion process. Move on to absorption. So to reach the reactive tissue, the drugs must make its way to the fluid circulating inside the body, which is the blood or plasma. Absorption refers to what happens to a drug when it's entered the body and it reaches the circulating fluids or tissues. Most medicines are absorbed from various body areas, for example, through digestive tract, orally, rectally, or through mucous membranes, skin, lungs, muscle, or even subcutaneous tissue. Drugs can be absorbed into cells through various processes, including passive diffusions, active transport, or filtration. In passive diffusion, what happens is that the drugs absorb in the body and occurs through concentration gradients. So when the concentration is high from the other side, then the drugs will move to the membrane with the lower concentration. And this not require cellular energy, and this is just quickly to happen when the drug molecule is small and soluble in water and fat, because the cell membranes are made of fat and protein, so it just like go through. And it doesn't need to have electrical charge that could detach it from the cell membranes. Well, unlike the passive diffusion, active transport is the process that actively uses energy to move molecules across the cell membranes. The molecules can be large or can also move against a concentration gradient. This process is not very important in drugs absorption but often involved in kidney excretion. The filtration in another process of the body is what commonly used to do the excretions of the drugs. So filtrations involve movement through pores in the cell membranes that can reduce the concentration gradient and as a result of attraction the plasma protein. So this is when the drugs is being pushed through the hydrostatic pressure, blood or osmosis. Next one is administration. So in clinical setting, the most frequently used administration site is the oral route. So this is not an invasive procedure and it's cheaper than other routes and it's also the safest one when the patient is administering drugs by themselves at home, for example, and when they have the oral medication. So the oral administration will then be directly to the intestine system, and the drugs will go across the several barriers that aim at destroying ingested foreign chemicals. As we know, the stomach is very acidic environment, and that's the main barrier for the drugs to get down the intestine system. So some of the drug compound or the chemicals will then be broke down because of the acid. In fact, pharmaceutical companies will then prepare the medical capsules of tablets to be like a really binder and wrap so that um, it will not be destroyed by the acidity that fast. So then it will stay until it will be then released for the absorption inside the liver. So when the food is present, the stomach is sometimes higher in acid, and then the stomach will empties very slowly and exposing the drugs into the acidic environment for a long time period. Then certain food also increase the stomach acidity, such as dairy products, alcohol, and protein, and also speed up the breakdown of many medications. Other food can also chemically bind to the drug or inhibit its absorption, and this reduce the barrier effect so that mostly, oral medication should be given 1 or 2 hours after eating. Some drugs cannot be maintained in sufficient quantity when given orally, so that they need to be injected directly to the body. Now let's talk about injection. So some drugs, it will then be injected intramuscularly or IM, like this one. It's like 90 degrees. You insert through the muscles and release the the medications here. So then it will be absorbed directly into the capillaries in the muscles and sent into the circulations. This takes time because the capillaries must carry the drugs to the veins. But because men have more blood vessels than women, IM drugs in men reach peak levels more quickly than women. Another injection that we are very familiar with is what we call subcutaneous injection. So you pinch and inject, and this is what happens when you pinch. You pinch the skin. Hopefully, it will go then to the subcutaneous side, and then here is where we put the medication. So it the medicines or the drugs are then deposited through the under the skin area, which then slowly absorbing it into circulation. The circulation times varies with subcutaneous injections, depending on the fat content of the injection area and local circulatory condition. Now let's see on the various route IV, IM, SC, PO, PR, mucous membrane, sublingual under the tongue, and buccal by the cheek, and topical the skin, and inhalation through the breathing. So the factors that influence drug absorption can be many things. Mostly that has nothing to interfere is IV because it's go directly to the venous system. So it's like very, very prone to cause um, medication error if you're not doing the six rights. And then you have the IM, as we talk about, that then be distributed to the muscle fat content. And we have the SC also to the tissue fat content, and sometimes temperatures can cause um, quicker or slower absorption, as well as PO. Well, with PO or orally, the gastric acidity and the length of time in the stomach will be then the one that influence the drug absorption. And we have also PR, sometimes there's lesion, and it will then help the absorption because of that. And then we have mucous membrane, which is very quick, and then we have topical. Sometimes it has to do with the skin integrity, and also we have inhalation. Sometimes we also need to deal with the lung integrity, and then we just need to see whether the drugs is then administered appropriately through inhalation or it was just going through open air. So as you see here, there are a lot of routes of drug delivery. We talk about this one, two: intravenous, intramuscular, subcutaneous, topical, inhalation, transdermal, intrathecal inside the um, thoracic, and then sublingual, and then rectal, and then portal circulation because it's oral one. Here also, we see how we administer medication. Now let's talk about the first pass evac or first pass metabolism. So first pass effect or first pass metabolism is actually how the drugs is given orally and then absorbed from the small intestine directly into the portal vein system or the blood vessels that run along the liver when the blood returns to the heart. So the portal vein then will deliver the absorbed molecules to the liver, which then immediately the liver will convert the most chemical to the series of liver enzymes. These enzymes then will break down the drugs into what we call metabolites. And then the metabolites will then cause effect to the body, and some which will be inactive then be excreted from the body. As a result, a large percentage of oral dose is destroyed at this point and never reaches the tissue. This is called first pass effect. The recommended doses for the oral medications may be higher than those for parenteral medications, considering this pass effect. So let's have this example. So we have a drug. Once we swallow the drug, we have 100. Okay, and then the drug will go to the digestive system. Once it's because of the acidity of the stomach, the drugs then will remain only 50. Then the drug will enter the hepatic portal system, right? And then will be break down to the metabolites, and then it will remain only 25. It will enter the liver system, and then the 25 that stays here is the one that will be distributed to the area where the drugs is needed. So instead of having 100 from the beginning, the one that will actually being distributed is only 25. I hope you understand this. This is what we call the first pass effect metabolism. Next one, we need to focus on patient safety. So The liver is important in the metabolizing drugs, and the kidney are responsible for the drugs excretion from the body. So it is very good if you or we as a nurse always check with the patient's liver and kidney function before we start a drug regimen. If the liver is not functioning properly, medications then may not be metabolized properly and can reach toxic levels in the body. If the kidney are not working properly, the drug is also not being excreted properly and can accumulate in the body and cause toxicity. So we need to have dosage adjustment, or we do adjustment just to consider if the patient has a kidney or liver problem. Remember, the drugs will go from the stomach, going down to the intestine, then move to the liver, to then be transformed as metabolites, and then will then go throughout the body. But then, if it's not being absorbed through wherever it's needed, the drugs will then be excreted through the kidney, or some of them will go through the intestine to be then out from the rectal or to be out from the bladder as urine and as feces. Now let's talk about distribution. So distributions of the drugs can be from protein binding, blood flow, and also body tissue affinity. Then these all will cause the pharmacologic effect. It includes the movement of the drug to the body tissues. There are factors influencing distribution, including fat-soluble ion formation and reactive tissue perfusion. For example, tissue perfusion is a factor in treating diabetes patients who have infections in the lower limbs and require antibiotics to destroy bacteria in the area. In this case, systemic medication may not be effective because part of the disease process includes changes in the blood vessels and decreased blood flow to some areas, especially the lower extremities. If there is insufficient blood flow to the area, little antibiotic will be delivered to the tissue and little effect will be seen. Likewise, if a patient is in a cold environment, may experience vasoconstriction in the extremities, there will be preventing blood flow to the area, and circulating blood will not be able to deliver drug to the area, and the patient will receive little therapeutic effect from the drug intended to reach the area or the tissue. Now, let's talk about protein binding. So most drug, it will bind with the protein in the blood to be carried into the circulation. The protein drug bone is relatively large and cannot enter the capillaries and the tissue to react. The drug must be freed from protein binding in the tissue. Some drugs bind very strongly and are released very slowly. This drug has a very long durations of action because it is not free to be broken down or excreted. It will be very slow to be released into reactive tissues. But some drugs do not bind strongly. They work quickly and are excreted quickly. Some drugs also compete with each other to protein binding, altering the effectiveness or causing toxicity when two drugs are given together. Many drugs bind to proteins and are not fat soluble, and these drugs cannot be distributed to the central nervous system because of what we call blood-brain barrier, which is very selective in allowing fat-soluble substances to enter the central nervous system. So the drugs, this is a free drug molecules, it will then be binding with the drug protein, but then it will go through the tissues, capillaries, or anywhere that it's needed. But then if it's blood-brain barrier, it won't be going to the central nervous system because it's not fat-soluble substances. Now let's talk about the blood-brain barrier. The blood-brain barrier is a protective system, cell activity protection that protects many things such as the entry of foreign objects and toxins in the central nervous system. The fat-soluble drugs most easily cross the blood-brain barrier and reach the central nervous system. So the fat-insoluble drugs, they are unable to cross the blood-brain barrier one. This is clinically important in treatment of brain infections with antibiotics. Almost all antibiotics are fat insoluble and cannot cross the blood-brain barrier. So, the effective antibiotic treatments can only occur if the infection is bad enough to alter the blood-brain barrier and allow the antibiotics to pass through. Next is about placenta and breast milk. Okay, so many drugs easily cross the placenta and affect the developing fetus of a pregnant woman. That is why it is better not to give pregnant women any medication because it is having a possible risk to the fetus. Medication should be given only when the benefits outweigh the risk. Many other drugs are excreted in breast milk and potentially affect the neonate as well. Because of this, nurses should always check the drug's ability to pass into breast milk when administering medications to a nursing mother. Now let's talk about pregnancy safe index. So we have category A, B, C, D, and X. So category A and B, it's safe for pregnant women because category A have done studies that then taking these medical medications will not cause any risks to the fetus in the first trimester of pregnancy. And category B, it's shown it has not shown any risks to the fetus, but then there are no controlled pregnant women in the study, so they don't have the evidence yet. For animals it's okay, but then for human it's not been studied yet. Now we have category C. Category C is a cross no. It causes a side effect to the fetus or teratogenic. And then category D is also no because it has the positive evidence that cause risk to the fetus. And category X is also no because it then demonstrated abnormalities and demonstrated fatal risk. So this category X is absolutely contraindicated for the women who are pregnant or who may wish to become pregnant. Next, let's talk about biotransformation or metabolism and liver enzyme system. So as we mentioned, we have the ATME. So the biotransformation contain or can be called as metabolism. So this is where the enzyme in the liver detoxify the foreign chemicals and protect the homeostasis of the body function. So all the drugs will then be metabolized here, will then change the cytochrome P450, then it will then be absorbed to the body to cause like good things inside the body. Liver enzyme system is what we talked before. So as the liver is the most important area for drug metabolism and biotransformation, the process happen here where the drug is converted into a new less active chemical and then be absorbed through digestive tract or even through the tissue and cause therapeutic effect that we want to happen within the body. Now, there are stage 1 and stage 2. So stage 1 is where the drug oxidations, reductions, and hydrolysis via cytochrome P450 enzyme system happen, and this is inside the liver. And then we have what we call conjugation reaction, where then this drug being absorbed or then being easily excreted through the kidney. So then some of the enzyme in the liver will speed up metabolism, but some also will inhibit the system and make the drug less effective. This action also explains why liver disease is often a contraindication or a reason for the use of caution when administering certain drugs. If the liver is not functioning effectively, the drugs will not be metabolized as they should, and then it will cause the toxicity higher or quickly occurred within the body and will not cause therapeutic effect. So this is what it is. So you have the phase 1 where the P450 enzymes happen to then cause the medicine to like be cut down to the metabolites that will be absorbed. And then we have the conjugation pathway. So some of them goes to wherever it's needed, and some that is not being used then be excreted through the bile, serum, kidney, feces, urine. So it then goes out of the body. So, the drugs that stimulate or increase activity is nicotine, alcohol, glucocorticoids. The drugs that inhibits is ketoconazole and quinidine. Now with the excretion. Excretion is the removing of the drug from the body. So the skin, saliva, lungs, bile, feces are some of the routes that use to excrete drugs, and the kidney play the most important role in drug excretion. So the drugs, where they are water soluble, they can easily be excreted from the kidney through the glomerular filtration, where the movement of the water and water soluble component through the plasma to the renal tubules. Some of the other drugs, they are hard, so they need to be secreted or reabsorbed through the renal tubules with the active transport system. The urine acidity is also an important part of excretion. So active transport system that move drugs to the tubules convert the drugs into acid and bicarbonate molecules. It is important to consider patient's kidney functions and urine acidity before administering a drug. And the kidney dysfunctions or damage can result in the toxic level in the body because drug cannot be removed or excreted. Next is what we call half-life. Half-life is the time required for the drugs to be in the body and decrease into the half-peak level previously achieved. For example, we have a drugs here, 20 milligram, half-life is 2 hours. So then that after 2 hours will be only 10 milligrams, and after 2 hours that will be 5 milligrams, and the 2 hours later will be 2.5, and then it will be gone from the body. So this is important to determine the right time for drug dosage and also determining the durations of the drug's effect on the body. You can have a read on this one. So if we have like 50 milligram for 12 half-life of 12 hours, it will then take 4.5 or 5 days for the drugs to then be out of the body. So, with the half-life, the rate of absorption, distribution to the tissue, and rate of biotransformations and how quickly drug is being excreted all are considered when we determine the half-life of a drug. And this is literally being counted in a healthy person. So if a person have a renal or hepatic dysfunction, this might be prolonged in the time required for excretion, or then we need to change the dosing so then it will be able to be effectively excreted through the body. So as a nurse, we need to know the drug half-life so that we can explain the importance of medication administration schedule at home or in the hospital. Now, the effect of a drug administration on the critical concentrations of the drug. So this is when it's administered intravenously, this is when orally. So we have the critical concentration here. And the drug life for oral is longer than the drug half-life when it's intravenously administered. And then we can see in the day one, it will reach the critical concentration, and then half-life, it will go down the next day, and then in we give another one, it will reach up again and then get down. So this is why we need to see this is taken today at 10 a.m. this is taken tomorrow at 10 a.m. so it needs to be taken again so it can have the critical concentration. All right, now we've talked about this pharmacodynamics and pharmacokinetics, and we talk about this absorption, distribution, eliminations, and excretion. And then we learn about this as well. So no matter from which source, parenteral, topical, or oral, the drugs will then have the pharmacokinetics when it then be inserted into the systemic circulation, and then the body will respond it as a pharmacodynamics, as a mechanism of the drug at the target site, and then it will have the therapeutic or clinical responses. Now, as a nurse, we need to think about the factors that affecting the drug effects. So we must be aware that there are human factors that influence tremendously on what happened to the medications when it enters the body. And between two people, the reactions are never the same. And the pharmacodynamics and pharmacokinetics of the drugs needs to be remembered that it was studied on a healthy adult man, which then varied in the clinical setting because we have a lot of patients with different diseases and health condition. That's why, as nurses, we need to consider a lot of these factors when we administer the drug, such as weight, age, gender, physiological factors, pathological factors, genetic factors, immunological factors, psychological factors, environmental factors, drug tolerance, and accumulation effect. Let's talk one by one. Body weight. So normally the drugs is like then be recommended to be used by a human 60 kg, but then there also varies between each drug. So we need to think that probably the thinner the people, they may need smaller dosage, and the toxic effect may happen because we did not administer medication according to the body weight. Mostly the babies, they have different dosage with the adult. Well, then here also age is having a factor. So when the children, they don't metabolize as quickly and as mature as adult, we need to then consider specific dosage for children which are different with the dosage of an older people who experience aging with decreased functions of liver and kidney. So then we also have the geriatric recommended dose. As nurses, we need carefully monitor the expected effect, and if the effect is not as expected, we probably need to do dose adjustment. Next one is gender. Physical differences between men and women can then influence the effect of drugs. And IM given to men is higher effective rather than to women. And also women, maybe we need to also consider the possibility of pregnancy as some medications are not safe for pregnant women. We also need to consider the physical factors such as the nervous and endocrine system, acid-base balance, because some of the drugs, they will then cause um, effect on the acid base and electrolyte levels. So before administering the drugs, we need to make sure that they do have what we need before we administer the drugs. As well as immunological factor, as people can develop allergic reaction to certain medication, we can be sure that once we administer the medication, they don't develop drug sensitivity, which can range from dermatologic evac, from anaphylactic, even shock, and also death. Next one is pathological factors. So here we want to treat the disease, but then we also need to see how the chemical reactions alter the response in the body. So for example, gastrointestinal disorder can evac the absorption of oral medication. So we need to give then another route of medication as the gastrointestinal is not functioning very well, as well as if the patient have vascular disease or low blood pressure. When we distribute the medications inside the body, probably then it won't be making the desired therapeutic effect because the blood flow is not very good. Even with liver and kidney disease, we need to see also whether this then be a toxic or this be therapeutic to our patient. Genetic factors also play important roles. That's why we need to see that some people have more enzyme system because of their genetic factors that break down the drug very quickly. And we also have to see that maybe they have a factor that then slower the effect of medications. Psychological factors deal with how the patient's attitude with the drugs has a real effect on how the drugs work. For example, we have what we call placebo effect. So the drugs, the patient thinks that the drug will work in their body and actually it will be effective. But then when the person think that it won't do anything to the body, then probably it won't do anything because it's the believing system, and it's how they accept the prescribed therapy. Environmental factors talk about, for example, if it's a calm, cold, and unstimulating environment for sedative medication, it will then increase the effect of the drugs. For example, the drugs is given in a very hot temperature, probably it won't be as effective as when the medications is given in a cold environment. Tolerance is how a body then become tolerance or resistance to the evac because of other pharmacokinetic factors. For example, if we use morphine a lot of time to a person, then the next time we administer it, it needs to increase the dosage. Cross tolerance can also happen because we have a resistance of the drugs within the same class, but then in several different situations. Cumulate is when we have a medications given in excessive dose inside the body, and then it can lead to toxic level and also adverse effect. This can be prevented by following the medication regimen precisely. So we then help our patient to have a strict adherence to the medication regimen. But then again, when they are doing their own therapy at home, sometimes it won't be as strict as what we hoped for. That's why it can cause what we call significant adverse effect, and then we have to educate the patients on what to do when it happened. Next is about interaction between drugs, so drug and a drug, or a drug and alternative therapy. So when two or more drugs are taken together, the drugs may interact with each other and cause an anticipated effect in the body. For example, herbal products with a drug. So this can increase or sometimes decrease the desired therapeutic effect, or both won't cause anything, or both can cause adverse effect. That's why it's important to really see the pharmacokinetic and pharmacodynamic disturbances that can be happening because of the therapeutic and the toxic effect of interaction. So interaction can also happen when two medication is being administered at the same time. As nurses, we need to consult the list of medication and indicate clinically significant drugs interaction. Sometimes this problem can be prevented by changing the medication or adjusting the dose. Now the interaction between drug and food. So some food are very acid, so then it causes the drug not to happen. And some chemical also reacted with the type of food. That's why we need to see if this medicine can be given without food or need to be given with food to then minimize the effect of interaction. Some medication also will cause the laboratorium test results changes. That's why we need to ask if a patient taken, for example, blood thinner, so the blood will not be thickening. And then we need to see if they are taking that. Once we do, for example, it's heparin. Once we do the result for um, the PTA-PTT, then the blood, because using of heparin, will be longer in the blood clotting. So we need to always ask what type of medications is being taken when we are going to do a laboratorium test. Next one is the determinants that affect the drug therapy. So there will be like clinical factors, administration form, pharmacodynamics, and also pharmacokinetics. Now, to achieve an optimal therapeutic event, as patient, we should follow the drug regimen so that we then receive the therapeutic effect, not the adverse effect. To prevent the problems, we have to be very strict and the best way to deal with the time. As nurses, we need to have the history of physical assessment so that we can observe the obvious problems and then know how it be treated appropriately. We also need to check the factors that influence the medication's effects, as well as we then be able to collaborate with the medical professionals to modify the effect. In many cases, nurses is in the best position to help patients assess the problems early. Well, happy learning to you. That's the end of these classes.